Okay, so if you're a pathology trainee, you know the feeling. You open up the CAP cancer protocol for a lung resection, and it just looks like this endless mountain of checkboxes. But what if you could see it differently? Not as a checklist, but as a roadmap to a super precise and powerful diagnosis. That's what we're going to do today. We're going to break down the lung CAP protocol so you can use it with confidence and really get why every single data point you report matters so much. So, why all the rules? Why is this protocol so rigid? Well, because it's our universal language. Think about it. It's the system that makes sure a report from a pathologist in one hospital means the exact same thing to an oncologist clear across the country. It's all about eliminating guesswork and making sure that every single patient's treatment is based on complete, consistent, and really high-quality data. And I'm not exaggerating here. We are talking about precision at the millimeter level. A tiny difference in a measurement, a subtle finding you almost scrolled past on the slide. These aren't just academic points. They can literally be the difference between a patient qualifying for a specific chemotherapy or not. What you see under that microscope directly shapes a patient's entire treatment journey.
And this is where synoptic reporting comes in. Don't think of it like writing a story. It's more like a structured interview. There's a specific question, like tumor size, and a direct answer, 2.1 centimeters. This isn't just about making things look tidy, it's a mandatory format. And it's designed for one reason, clarity. So an oncologist can, in a split second, find the exact data point they need without having to read through a whole paragraph of text.
So here's our game plan. We're going to walk through this exactly how you would in the lab. We'll start with that first look at the specimen, then dive into the microscope to really characterize the tumor. We'll map out its local spread, and then we'll pull it all together into that final TNM stage that drives all the clinical decisions. All right, the specimen is on your bench. You're looking at it, and you see multiple tumor nodules. Before you even think about making a slide, the first and most critical question pops into your head. What exactly am I looking at here? And this is the fundamental question you have to answer. Are these separate, totally unrelated cancers that just happen to show up at the same time? Or is this one aggressive cancer that's already started spreading within the lung itself? The answer you come to is a huge deal. It completely changes the patient's stage and their entire prognosis. This table basically shows you the decision tree. Just look at that top row, pathology. If the nodules look different from each other, one's an adeno and the other is a squamous, boom, they're treated as separate primary cancers. Each gets its own stage. But if they look identical, we have to consider them metastases from a single tumor. And that, as you can see in the next row, immediately changes the stage to a T3, a T4, or even an M1A. That has a massive impact on the patient's outlook. So, once we've figured out the focale, we move on to the microscope to get the story on the primary tumor itself. We're going to focus on three absolutely critical things: getting the size right, nailing the histology, and identifying a very specific, and now required, type of invasion. Now, this is a big one. For non-mucinous adenocarcinomas, how we measure the size is super nuanced. The official T stage is determined only by the invasive part of the tumor, so the areas with those more aggressive patterns like acinar, papillary, or solid growth. You still have to measure and report the total size, which includes any of that non-invasive lipic stuff growing along the lung's normal architecture. But remember, it's that invasive dimension that dictates the T in the final TNM stage. Next up, we have to be on the lookout for STAS, or spread through air spaces. Just picture it. These little clusters or even single tumor cells have broken off the main tumor and are now floating around in the nearby air sacs. This is a huge red flag for aggressive behavior. It tells the oncologist that even with a clean surgery, there might be microscopic disease left behind, and that means a higher risk of recurrence. That's exactly why reporting if STAS is present or absent is now mandatory. Okay, next we're going to zoom out just a little bit to see how the tumor is interacting with its local neighborhood. We're talking about the pleura, the surgical margins, and of course the regional lymph nodes. This is really where the T and the N of the TNM stage start to come into focus. And here it is, one of the most high-yield rules you absolutely need to know. For a tumor that's otherwise small, if it invades the visceral pleura, it's a complete game changer. It automatically bumps a T1 tumor all the way up to a T2A because it reflects a more aggressive biology. This image shows you exactly what we're talking about. See image D? That's PL0. The tumor is right up against the pleura, but it hasn't broken through that distinct elastic layer. Now compare that to A and B. Here, the tumor has breached that elastic layer. That's PL1. It doesn't even have to touch the absolute surface, which is what you see in C as PL2. The key is both PL1 and PL2 count as invasion, and both will upstage the tumor. This is why getting an elastic stain is so often essential. It helps you see that boundary crystal clear. Evaluating margins has to be a systematic process every single time. First, you identify all of them, your bronchial, your vascular, and that parenchymal staple line. Second, you measure the distance from the invasive tumor to whatever margin is closest. And finally, you have to be specific about what's at the margin. Invasive tumor is the big one, of course, but even reporting carcinoma in situ or a lipidic component is crucial because it could influence decisions about radiation or follow-up. You know, the lymph node map can look really intimidating, so let's just break it down into simple zones. Think of it this way. N1 nodes are local. They're inside the lung or right at the root, the hilum, on the same side as the tumor. N2 nodes are one step further out, in the middle of the chest, the mediastinum, but still on the same side. The second that cancer crosses the midline to the other lung or goes up into the neck, that's N3. And that distinction is absolutely fundamental to staging. One last point on nodes. Extranodal extension, or ENE. This is when the tumor literally breaks out of the lymph node's capsule and into the fat around it. Now, it doesn't actually change the PN number. An N1 node with ENE is still just an N1, but you must report it. It's an important adverse prognostic finding that tells the clinical team this disease is more aggressive. All right, we've done the hard work. We've collected all our data points on the tumor, the nodes, and the local invasion. Now it's time to put it all together and build that final PTNM stage classification. When it comes to the T category, I want you to remember this one thing. The ruler isn't the only tool that matters. Often, where the tumor is going is way more important than just how big it is. Let's just look at a quick comparison. A PT1 tumor is 3 centimeters or less, and it's nicely contained. Simple enough. But a PT2 tumor can either be a bigger tumor, sure, or it can be a smaller tumor that has one of those aggressive features we talked about, like that visceral pleural invasion. This really shows you how a specific type of invasion can make a small tumor behave like a much larger one. 20%. Just remember that number. For grading invasive non-mucinous adenocarcinomas, it's a critical threshold. If at least 20% of the tumor is made up of a high-grade pattern, like solid or micropapillary, the entire tumor gets classified as poorly differentiated, or grade 3. It's a simple rule, but it carries some serious prognostic weight. So finally, let's bring all these technical details full circle, back to their ultimate purpose, giving the clinical team the critical information that is going to guide patient care and, really, define their future. This quote from the AJCC says it all. Yeah, the clinician officially signs off on the final stage, but let's be real. Their decision rests almost entirely on the data that you provide. Your report is the source of truth. The accuracy of your measurements, the details in your descriptions, all of that raw data becomes the definitive stage for that patient's cancer. So, the next time you open a CAP checklist, try not to see it as just a series of boxes to tick. See it as the narrative of a patient's disease. Every observation you make, every measurement, every detail you record, it's a sentence in the most important chapter of their story, the chapter that determines their fight against cancer.